Hi everybody, one more time. We're almost finished for this week. This is the last video. It is unit number 5. Of course, this is week 2. We're going to now review all the cardiac drugs. We're going to just kind of go straight on through the whole section there. So if you want to go ahead and print off all of the handouts for the cardiac section, unit 5 on week 2, and we'll make it through them. I hope this is still helping you. It's a lot of work, and now I know you guys are trying hard. You're doing a great job, so keep it up. Just want to point out, if you want to go through as a quick review on the cardiovascular system, if you're having a little bit of trouble getting that whole thing together, there's a really good 2-page review in the new book in 7th edition. I don't know where it is in an earlier edition, or even if it exists. I'm sure something like it does. But there's a good review on page 615 over the cardiovascular system, and I read through it, and it's a down and dirty, quick little just to get your mind thinking in the right direction as we go through all of this. So anyway, so let's start. We're going to start on the first group there. It's in chapter 40 of the 7th edition. This reviews the cardiac glycosides, the antianginins, and the antidysrhythmics. This group of drugs regulate heart contraction, your heart rate and rhythm, and also the blood flow going through the myocardium. So we'll start out with the cardiac glycosides. Cardiac glycosides are a group of drugs that inhibit the sodium-potassium pump. This in turn then increases the intracellular sodium that leads to an increase in the influx of calcium during the heart cardiac muscle fibers. What it does is it causes the cardiac muscle fibers to contract more efficiently. And we'll talk a little bit more about that when we get into this a little more. All right, one of the cardiac glycosides are used to help treat heart failure. And heart failure, or cardiac failure as it's known, with reference to cardiac failure, which is actually like a later stage in this, is when the heart muscle weakens and it starts to enlarge, it loses its ability to pump blood through the heart and into the systemic circulation. Okay, this is heart failure. This is pump failure. So when the heart muscle weakens and it gets enlarged and it's not pumping, it's floppy instead of doing its good old pump like it needs to be doing. It loses its ability to get that heart through the heart and into the circulation. So that's when you start having the heart failure. When the compensatory mechanisms that are in place, they fail, and the peripheral and the lung tissue then start becoming congested. So you've got some backups there. So when the muscle itself starts failing and it starts enlarging and getting weak, then there's backup measures within the body that kind of help push that heart to keep on beating. But then when that starts failing, then you have some backup, and it starts backing up into both the peripheral tissues and into the lung tissues, and what you see is edema or congestion. When it gets to that point, that means then the heart is in congestive heart failure, and that's what that term is. Some of the causes for this heart failure are chronic hypertension. Maybe the patient had a myocardial infarction, coronary artery disease, valvular disease. If your valves aren't functioning right, then there's a backup of fluid. It can be a congenital heart disease that developed, or just a part of the aging process can also cause it. There is right and left-sided heart failure, and I know that's sometimes a little bit difficult to understand, but if you think about it like this, okay, when the left ventricle, and this is left-sided failure, when the left ventricle does not contract sufficiently to pump that blood back into the circulatory system, then that causes excessive amounts to start backing up. And where does that blood come into the left ventricle? Through the left atrium down into the left ventricle to get pumped out from the lungs. So when that starts backing up and that can't get in there, the fluids go back into the lung system itself. So then you start seeing shortness of air, you see dyspnea, and those types of things. That is left-sided heart failure. As compared to right-sided heart failure is when the heart doesn't pump the blood into the right atrium from the systemic circulation. So there's a problem with the right side of the heart, and it's not pumping it through that atrium from the circulation. So if there's a problem in that right side, so it's not even getting to the lungs yet. It's coming in there. We're supposed to be getting it in through the pulmonary artery, into the lungs, but what's happening is that blood starts backing up into the peripheral systems and into the tissue. And so then what, on the right side heart failure, you see the peripheral edema. And of course, gravity pulling the edema down, you'll start seeing it especially in their ankles and their feet and their legs. But it can swell and just continue. One type of heart failure, whether it's left or right, can always end up leading to the other. And so then they can have both heart failures on both sides. The myocardial hypertrophy, when you see the enlargement of the heart, that's because it's a muscle. And anything, like say if I was pumping irons to make muscles, well, that'd be a trick. But anyways, if I was, well, then hopefully my muscles would then grow to be able to take care of that. So your myocardial hypertrophy results in your cardiomegaly, so you get an enlarged heart, just like you get an enlarged muscle. This is a major problem with progressive heart failure, and increases some of the problems that we have with it. So then you think about the pathophysiology that's taking place. You've got a preload, which is the excess blood volume in the ventricle at the end of diastole. So you've had your contraction, and now whatever's in that heart before it, as it starts to refill, that's your preload. If you've got a problem with that and excess, then you have an increased elasticity of the wall with a weakening of the heart. So that's your preload. Preload is before it pushes it after. Now afterload is the added force that it takes to get that ventricle wall to pump that blood through the aorta. And that can be due to excessive resistance of the aorta, and it must be overcome to open up that aortic valve. So that's preload and afterload. So to treat this, there are some measures. There are non-drug measures to treat heart failure. We try to do those in general. We teach this to all patients that have some heart failure. But if they're just having some mild heart failure, then these are some of the things you can mention to kind of help them get started in trying to change things before they go any further. And that's like limiting salt intake. So you want to limit it to a 2 gram per day diet. That's about a teaspoon of salt total. And you've got to think about all the salt that's in all the foods, the manufactured foods, and the salt that they actually sprinkle on their food. We need to encourage smoking cessation. That just deprives oxygen to the heart. So it's something that has to stop to allow that heart to be able to have its oxygen. You need to avoid alcohol or limit it to just 1 drink a day, again with the oxygen deprivation. Obesity, unhealthy behaviors, we need to try to encourage some mild exercises tolerated. You don't want to work that heart too hard, so you've got to be careful whenever you encourage somebody to do exercises like that. So just think about that when you're doing that, when you're encouraging things like that. One of the drugs that we use on patients with heart failure is digitalis. And digitalis, it has been used ever since the 1200 ADs. And it's still used in its purified form. It is obtained from the foxglove plant. But it can be poisonous. That's a plant that is poisonous. In 1785, William Weathering, he used dig to alleviate dropsy. That's what they called it back then. Dropsy was edema of the extremities, and it's caused by both cardiac and kidney insufficiency. But they didn't realize it back then that dropsy was just a result of heart failure. You know, that again, we were talking how that right-sided heart failure. And they found it to be very helpful. The thing about digitalis or digoxin, it has 3 different actions. It has a positive inotropic action, and remember inotropic, the positive reaction of that is it increases heart contraction and the stroke volume. So the inotropic is the contraction, right? The stroke volume. the negative chronotropic action, which means it decreases the heart rate. And it has a negative traumatropic action, which decreases the conduction of the cell walls. So that's what the digitalis does. And by doing that, it strengthens the cardiac and the peripheral and the kidney function by increasing your cardiac output. It decreases preload and improves the flow of blood. By doing this, it improves the flow both to the periphery and to the kidney. And in doing that, then you decrease the edema. So today, though, digitalis is basically a second-line drug. It's not used as much as it used to be. It's used, but there's others out there. So the first-line drugs in heart failure are mostly your inotropic agents like dopamine, dobutamine, or your phosphatidylase inhibitors like Inocor and Milrinone, which is your Primacor. Other drugs that we use for heart failure more on an outpatient basis and in-house, but they're PO form, are your diuretics, your beta blockers, and your ACE inhibitors. And we'll talk more about them. That last little part on this slide is about the lab tests that are done. Atrial natriuretic peptide, your ANP, and your brain natriuretic peptide, BNP, are common. BNP is more sensitive than the ANP, and so we use that more. If you have a patient that comes in and is having some shortness of air, dyspnea, this is a good test to find out if they are having just dyspnea from that or if they are fluid overloaded. The desired of that is like less than 100 PGs per mil, but these can be elevated, especially it's in older women. You can even see it up into like in the 160s range. So we don't think of it as being heart failure until it's elevated greater than 400. This is a secretion from the atrial cells themselves, and so it's a good marker for heart failure, and it's well accepted within the cardiac community. If you look on the slide there with the ACC and the AHA, that's the American College of Cardiology and the American Heart Association. These are their stages of heart failure. This is a nationally accepted. On table 42-1, it goes into it a little bit more, and it actually does tell, because you have to stage. If you've got a patient that comes in, you need to stage them and decide where they are within their heart failure, and then you can think about how you're going to have to address their needs. Again, cardiac glucosides, their function, it's positive inotropic action, the negative chronotropic and negative dromotropic action, and it does increase the stroke volume like we talked about. All right, let's talk a little more about the digoxin, lanoxin. It is very potent. It can be given either PO or IV. It is absorbed 70 to 90% through the GI when you give it, 70 with the PO, 90% with the IV. It has protein binding capacity of about 30%. It has a long half-life. It can be anywhere from 15 to 40 hours. So it's a drug you have to kind of pay attention to with the toxicity problem. Drug interactions with this, there's when you take protein wasting diuretics, you got to think about that. You get hypokalemia, and that increases the chance of drug toxicity with this. Antacids that decrease the absorption of this medication, and also there's a lot of different herbal interactions with this, like ginseng, for example, will give you a false high level when you take a test on it. St. John's wort decreases absorption. Metamucil, again, decreases absorption. And then, just an FYI, because I remember when I was in nursing school learning about this, licorice, that's the black licorice, will increase the effect of this drug, and it promotes a potassium loss. So with the two together, then you have an increased chance of having some dig toxicity. And ephedra, like we talked, is in a lot of the over-the-counter type weight loss medications. It will also increase the chances of toxicity. So your toxicity is either from an overdose or an accumulation. Signs and symptoms of that is your nausea and your vomiting, bradycardia, And if that's, anything less than 60 beats a minute. That's why we check an apical pulse before giving that for at least a minute. You can have dysrhythmias, headaches, vision illusions. You start having things like the white, green, and yellow halos around objects. It can lead to malaise, delirium, confusion, and the older population is prone to this toxicity. The antidote for that, of course, is digibind. Digibind actually binds to the digoxin, and it's used for treating severe toxicity. That causes then the dig to be excreted in the urine. You have to monitor your drug levels closely, and dig tox, if not treated quickly, can result in first, second, or third degree heart block that may not be able to be reversed. Your inotropic agents, which we talked about before, which are more commonly used for this because they're more of a first line, they inhibit that enzyme phosphodiesterase, and with a positive inotropic response that causes vasodilation. You will see that with those meds, you'll see an increased stroke volume, an increased cardiac output, and a promotion of that vasodilation. IV, you usually don't give that any longer than 48 to 72 hours. And these patients need to be monitored both with a cardiac monitor and blood pressure, and possibly even using like an arterial line, central line to monitor fluid levels, cardiac status, and what's happening within the body. So it's important that these are closely monitored. Or let's talk a little bit about your anginal drugs. Anginal pectoris, that's acute chest pain. It's due to either not enough blood flow going to the heart, or it can be due to a plaque that has lodged itself within the heart somewhere, or it can be a spasm of the coronary arteries. This comes from the decreased blood flow, and there's no oxygen getting to that myocardium. So then the patient will then feel tight chest tightness or pressure. There's a picture of that figure 42.1 in the new book. I think this is from the older book. In the newer book, it's the same thing, but it's just turned the opposite direction. And it gives some steps for treatment for both the classic and the variant angina. There are actually 3 types of angina. Type 1 is classic. Classic is a stable angina, and generally that occurs with stress or exertion, but it's relieved with rest. And as compared to unstable, which is an emergency, that occurs frequently, and it's progressing in its severity. It's also unrelated to any activity, so it can happen to you in the middle of the night while you're sleeping, or it can happen while you're in the middle of doing something. That is kind of a sign for a pre-infarction about to happen. Both the classic and the unstable, stable and unstable, those are caused by either a narrowing of the vessel or an occlusion, like a plaque or a clot. Then you have on the other side of it, you have the variant. And the variant angiopectoris, that is either Prince-Metal or vasospastic. These occur because of vasospasms, and they generally occur at rest. So you might wake up with a chest tightness, or you feel like an impending doom happening to you, and it's because of a Prince-Metal, they call it. So some of the non-pharmacologic measures you can do are things like you avoid heavy meals, quit smoking, avoid strenuous exercise. Watch what's going to happen when there's weather changes, like if it's been, like I talked about with your respiratory, you're going from out working in the icy cold when you're not used to that. Excuse me. Emotional upset, those can cause it. So you want to tell your patients, encourage them with proper nutrition, to do moderate exercise, but they need to be cleared by a healthcare provider prior to starting that exercise. And if they are having that chest pain, to encourage some rest and relaxation until you can and take it slower and then start over again. Some of the types of anti-anginals, they work to increase blood flow by increasing the O2 supply and decreasing the demand on the myocardium. Nitrates, they were the first ones around, and they've been around since the 1840s. They cause general vascular and coronary vasodilation or relaxation. And in doing so, it decreases the myocardial ischemia that's taking place. These drugs, you don't give them when you've got really low heart rate, especially like if you're bradycardic, because you're already slowing everything down with them. So you want to not give them then, or if you're hypotensive. They're also not drugs that you can give for a person that has second or third degree heart block. Those drugs, those people already have a block in their current that's going through their heart, so if you gave them one of these medications on top of it, then you could possibly block out any more chance that they have. You never stop these drugs abruptly. They have to be tapered, especially the beta blockers. The side effects to these are headache, hypotension, dizziness, and some reflex tachycardia. Okay, then you have like we were talking, your beta blockers. You have the non-selective that these are like Inderol, Nadolol. These decrease the heart rate, but then they can also cause some bronchoconstriction because they do have both beta 1 and beta 2 blocking agents there. So then they made some that were a little better, and these are used most often. This is your atenolol or your metoprolol. These are selective beta blockers, and they work just on the beta 1 and not the beta 2, so you don't get that bronchoconstriction with these. But again, if you've got a low heart rate, you want to kind of avoid those. The side effects to these on both of them is you can still have some bronchospasm. You can have some behavioral or psychological responses to that. They can cause impotence. And you need to monitor. When you first give these to anybody, you want to monitor them and make sure that their treatment's going to go fine. Another type of anginal drug is calcium channel blockers. Calcium channel blockers were developed in 1982. There's a list of them there on your slide. They are both for stable and variant angina, and for certain dysrhythmias, and for hypertension. Most common ones that we use there are the cardizem, the verapamil, and the procardia, or nifedipine. Those are used quite frequently, especially the cardizem and the verapamil. These drugs, the calcium activates the heart contraction, so that increases the workload and the need for more oxygen within the myocardium. These calcium channel blockers, they relax that, and they relax the coronary artery, so the spasm is less, especially in the variant angina. And they relax the peripheral arterioles, so you have a decreased oxygen demand within the stable angina. Some of the side effects is you can get a headache with these, hypotension, especially with the procardia. You don't see it as much with the cardizem. Calcium channel blockers can change the liver and the kidney function, especially the liver, so you need to do periodic liver serum enzymes just to make sure everything's okay. And these can frequently be given with other anti-anginals like the nitrates, so they're usually given with a combination. Okay, now let's talk about your anti-dysrhythmic drugs. And dysrhythmia is any deviation from a normal rate or rhythm of the heartbeat. That's considered dysrhythmia. It can be a bradycardia, it can be a tachycardia, or it can be an irregular rhythm like a atrial fib or an atrial flutter. So it all depends on what's happening with the heart, and there's different medications to treat different parts of that. Now, dysrhythmia, that is a disturbed heart rhythm. So anytime it's disturbed or changed, that's a dysrhythmia. And arrhythmia is an absence of the rhythm. These two words are used interchangeably, and that's okay. That it's pretty much accepted. Now, your cardiac action potential, that's the electric transfer that occurs through the cardiac muscle cell, through the membrane. When the sodium and the calcium enter the heart cell, there's a depolarization of those cells, and that causes the contraction. Sodium rapidly enters, and that starts the depolarization. Then the calcium follows, and what that does is it helps maintain that depolarization just a little longer and helps maintain that contraction, so it's a good strong one. And as you can see on this little chart there, they've got this phase 0 through phase 4. What they're showing on that phase 0, that's when there's an influx of sodium, and there's a rapid depolarization caused by that sodium I was talking about that's rapidly entering in there, causing the start of the depolarization. Then you'll see as it rises up, and you got phase 1. Now you have had that contraction, and so it's initiating a repolarization, and that's with the termination of that sodium influx. But you've got that calcium following, so you still got that following, so it's maintaining that contraction a little bit longer. So into phase 2, that's that calcium influx, and then it plateaus, because it's like a little prolongation of that contraction. So then as you see it eases off. Now there's a rapid repolarization caused by the influx of potassium, because now the potassium is coming into the cell, and then it gets to where it's resting, and then in phase 4, that's when the membrane is actually resting between the heartbeats. So if you can kind of wrap your head around that, that's a lot to think about, but that's actually how a contraction actually occurs, with that sodium, calcium causing the depolarization and the lengthening of it, and then the potassium causing the repolarization. So they all work together to make things. And so these drugs then will then have to act on these certain areas of the depolarization, and that's what we look at to see what is it we need to happen with these drugs. So with your dysrhythmics, the mechanism of these drugs is to hopefully restore heart rhythm to a normal rhythm. And you have different classes of those. Your class 1 drugs, these are like well, let's just talk about the fast sodium channel blockers. So these are going to be the ones that are trying to block that sodium channel at certain places. The first one, the 1A, that's a slow conduction and prolongs the repolarization. And those are used on the atrial and the ventricle dysrhythmias. Plus, if you see some proximal atrial tachycardia, it's good for that. Or the supraventricular dysrhythmias. And drugs of that class are like Norpace, procainamide, Pronestal. Then you have your 1B drugs. These slow the conduction and shorten that repolarization time. And these are used on acute ventricular dysrhythmias. And this would be like lidocaine, so it works on the ventricle. And then you have 1C. These drugs prolong the conduction time with little or no effect on the repolarization. So they're actually increasing that conduction there. And these are used on life-threatening dysrhythmias. And it is a drug called Rhythmanol. It's not used a lot here in this area too much now. Then you get into the class 2 drugs. These are your beta-adrenuric blockers. They decrease the calcium that's entering. They decrease the conduction velocity, and they automatically start that recovery time, increase its recovery time. These are things like esmolol, which is your Bravoblock, or propranolol, which is Inderal. These are used for atrial flutter and fib. They're used for tachycardic arrhythmias and ventricular dysrhythmias, and also your supraventricular dysrhythmias. Then you have your class 3 antidysrhythmics, and that would be like amiodarone. They prolong repolarization. These are used with your life-threatening atrial and ventricular dysrhythmias. They are resistant. When you've tried other drugs to get things to stop, then we usually go to amiodarone. Yeah, it is a drug we use frequently, but it also has a prolonged half-life and can have some side effects, so we have to think about who we're giving them to before we give it. It is also an IV or PO form. Generally speaking, you start on an IV form where you get a bolus and start it on a drip in an ICU, and then tapered off and then put on a PO form of this med afterwards, and you take it when you're at home even. Then you have your class 4 antidysrhythmics. These are your calcium channel blockers. They block that calcium influx. They're used in supraventricular tachycardias, and they can prevent some proximal supraventricular tachycardias like PSVT. This would be your verapamil and your cardiazam. And some of these other drugs here that are listed are also used as dysrhythmics, especially like DIG. Phenytoin, that can be used if you're having arrhythmias that are digoxin induced, but it's not used often. Here's a few practice questions here. Sinus tach, or ST I guess would be the patient's name, has angina pectoris. His BP is 100 over 60. Nitroglycerin 0.4 milligrams sublingual tablet is prescribed when ST has anginal pain. Because of ST's health history, nitroglycerin could A. increase his blood pressure, B. decrease his blood pressure, C. have no effect on his blood pressure, or D. decrease anginal pain without any significant effects. So what do you think? It's B. It could decrease his blood pressure. And then practice question number 2. Nitroglycerin can dilate veins and arteries. For ST, nitroglycerin will A. reduce myocardial oxygen demand, B. increase vasoconstriction of the vessels, C. increase myocardial oxygen needs, or D. increase oxygen used by the heart. The answer to that is A. Nitroglycerin will reduce myocardial oxygen demand. That's its best thing it does. Alrighty, you want to take a break now, you can, or we can just plug on along. We're going to talk about your anti-hyperlipidemics and your peripheral vasodilators. So if you want to take a break, this is the time to do it, and you come back and we'll start again. Well, that was my break. Okay, this is in chapter 46 of the new book. Your anti-hyperlipidemics are drugs that help decrease blood lipids. And your peripheral vasodilators, those dilate vessels that have been narrowed because of vasospasms. So first we'll talk about the lipoproteins a little bit. There's 4 major categories to the lipoproteins. There's a chapter reference there in chapter 46 in your book, table 46-1, it groups them. First, in the lipoproteins, you have the high-density lipoproteins, your HDLs. Those are the smallest and the most dense of all of them. They are more protein than they are fat. They help remove cholesterol from the blood. These are actually the good guys, so you want these to be higher. They also transport cholesterol to the liver for elimination. Then you have your low-density lipoproteins. These are your LDLs. They contain a higher percent of cholesterol. They are 50 to 60% cholesterol, and they increase your risk of atherosclerotic plaques and heart diseases. So you want those to be low. You also have some very low-density lipoproteins, which is known as your VLDLs, and these contain mostly triglycerides, and less cholesterol than your LDLs. Then you have your chymicrones. These are the largest particles. They contain mostly triglycerides, and they transport fatty acids and cholesterol to the liver, so they're helpers. Then on your next slide there, there's things you can do to help your patient before they have to get on cholesterol medications. And if they just are having a mild rise in their cholesterol, these are some of the things you can suggest to them, and their doctor should also, or their healthcare provider. You need to reduce saturated fats in your diet. You need to reduce that total fat intake to less than 30% or less of a caloric intake. So you need to really look at that fat and decrease that intake. That's where the cholesterol is coming from, that in your heredity. You want to reduce your total cholesterol intake to 300 milligrams per day or less. You need to exercise, because exercise will help increase the HDL, which is your good lipoprotein, and you need to stop smoking. Serum lipid values, they need to be measured frequently, and they're usually routinely part of a regular physical exam, or if you have an admission to the hospital, they'll usually check that. If they're elevated, you want to go ahead and do a fasting level to get a more accurate picture, and that way you can kind of compare and see what's going on. On table 46-2, there are examples of those serum lipid values, so you can get an idea how those are. Then there's the drugs. If just the lifestyle changes don't do enough, then we have to resort to the anti-hyperlipidemic drugs. And these actually, there are several types. They have been around for a while. These were first the resin anti-lipids, or the bile acid sequestrants. These were first developed in 1959. They were the first type, and what they did was they actually decreased the LDL by binding with the bile acids, and then they would be in the intestine, and then they would be taken on out of the body. They're not used too much anymore. Then you had your folic acid derivatives, and these were like Lopid, is what was one of the names of those drugs. It decreased the triglycerides and the very low density, cholesterols, your VLDL levels, but it didn't have any effect on your, they're the ones, they compete with the protein sites. So that's the ones, if you were taking it with any anticoagulants, you had to make sure and monitor your INRs, because there were some problems there when in the patient that also had to take anticoagulants. Then you've got your nicotinic acid, which is your niacin, which is a really good drug, and it's available even today, even over the counter. It's a vitamin B12 is what it is, and it actually lowers the VLDL and the LDL. The problem with it is that there are numerous side effects, and so people tend to not want to take it. It also takes a larger dose to make it start working, but it does work very well. About 20% of people will tolerate it just as it is, but you can teach your patients about taking this drug. You take an aspirin with it like 30 minutes before you take it, and the side effects then are decreased. The worst side effect, and the one that makes people kind of want to not take it, is that they get this flushing. And they'll actually, shortly after taking it, they'll get a red flush. And their face will be red, they'll look like they've got a sunburn, and they will feel hot, and they don't feel comfortable. So it doesn't last, it passes. But the thing is if they take an aspirin prior to taking the niacin, then they will have less likelihood of having that happen. And it's a good drug. Then you have your cholesterol absorption inhibitors, and that's drugs like Zetia, which decreases your dietary absorption. It decreases your LDLs, your cholesterol, and your triglycerides, but you only see a small increase in your HDLs with this. So most times this is something that they've had to combine it with a statin for optimum effect. Then in 1987, that's when the statins were developed. And these were like the best thing that could have happened. They inhibit the enzyme, the HMG-CoA reductase in the cholesterol biosynthesis. So when the cholesterol is synthesizing, this inhibits the liver from producing that HMG-CoA reductase. So, by doing so, your statins then decrease your LDL, and then there's a slight increase with your HDL with those drugs. Examples of that is like Zocor, Lipitor, your simvastatin, your atorvastatin. And these have been shown to be extremely useful in decreasing coronary artery disease and decreasing mortality rates. So these are like the top guns. These are the ones we're using now. Statins can also be combined with other drugs, and they are like lovastatin and niacin are combined, and they make Avicor, so that gets the effects of both the niacin and the statin. There's some drugs that they're combining with that help decrease blood pressure while taking them. So there's a lot of things out there they're trying to do with that. Now, one thing to know, and to make sure your patients know, that if this person was someone who tends to have high cholesterol or high LDLs anyways, and they stop taking their anti-hyperlipidemias, they stop taking these drugs, their levels will return to their pre-treatment levels. So just so that they are aware of that and kind of encourage it. You have a list here of all the different statins that are available. Simvastatin is one of the most often used. Lipitor, I would say, or the atorvastatin, that's probably second in that group. But they're all there available, and you can refer them to, there's a table on 46.4 that lists them all out there. Your protocols for atorvastatin is on 46-1, and also kind of refer through that nursing process of the use of statins. Now, one of the side effects you have to be aware with these statins is that they can cause liver impairment, and they can also cause rhabdomyolysis, which is a skeletal muscle disorder where it's actually breaking down the muscle, and then you start seeing it in the urine. So those are things we have to be aware of with that and be paying attention. Some of the things we need to make sure to do is we need to monitor liver enzymes and report any unexplained muscle tenderness or weakness, any fever or malaise that the patient is having. That can be a sign that there's some rhabdo starting in. We'll talk a little bit now about the peripheral arterial disease. This is when your arteries become occluded. This is the primary cause to that is your arteriosclerosis and hyperlipidemia, which the hyperlipidemia then results in your arteriosclerosis. So it's kind of like a mixed thing there. Treatment for that, it's a peripheral vasodilators that help to improve the blood flow. That's the whole purpose. It's a common problem in older adults, both the peripheral arterial disease and the peripheral vascular disease. It's characterized by numbness and coolness of the extremities. There can be intermittent cultication, and what that is pain or weakness of a limb when either walking, but the symptoms, they resolve when it rests, or even as far as leg ulcers developing in areas. Your peripheral vasodilators, there are several classifications of those. Your alpha-adrenergic antagonists, their job is to increase circulation due to this blockage or this peripheral vascular disease that's taking place. They can be things like Raynaud's, which you'll see in the hands more, arteriosclerosis, cardiovascular insufficiency. These drugs work on the smooth muscle, and one of the types is the isocyroprene. And in your book there's a chart about that on 46-2 about the isocyroprene. You can read a little bit more about that because it's a commonly used drug. There's also your beta-adrenergic agonist used for this, direct-acting peripheral dilators. There is the hemorrhagic, and those are like the P-tol. And then there's other things you can do. There's some selective antihypertensive that also work for that. Okay, practice question number 1. The patient's serum lipids are a cholesterol of 197 milligrams per deciliter. You have an LDL of 110 milligrams per deciliter and an HDL of 35. The nurse knows what about these values? A, serum lipids are within desirable levels. Are they? Because look at that, your LDL is 110. Okay, cholesterol is within a desirable level, but LDL and HDL are not. Cholesterol is not within desirable level, though the LDL and the HDL are. Or D, cholesterol, LDL, and HDL are not within desirable levels. Well, I'll give you a clue. Your normal range is your cholesterol is 150 to 200, your LDL is less than 100, and you want your HDL 45 to 60. Higher the better. So it would be B. Okay, the nurse who is given Lipitor, atorvastatin, realizes the importance of monitoring for which of the serious adverse reactions. And that would be pharyngitis, rash or pruritus, rhabdomyolysis, or agrelocitosis. And it would be C, rhabdo. Serious adverse reactions of avostatin include rhabdomyolysis, myalgia, photosensitivity, and cardiacs. Less serious side effects include headache, rash, pruritus, constipation, diarrhea, sinusitis, and pharyngitis. Alright, you can take another break for a few minutes, pause it here, and then come back. We're about to talk about now the antihypertensives. We're getting there. Alright. I'm doing a commercial for Bard's Diet Root Beer. It's very good. Alright, let's get on with the antihypertensives. Okay, this is chapter 44 in your book, in the new book. Hypertension is increased blood pressure such that the systolic, which is your top number, which you all know, is greater than 140, and your diastolic is greater than 90. So there's essential hypertension, and that's the most common, and it affects 90% of persons with hypertension. There's contributing factors to this. It may include a family history of hypertension. You may have hyperlipidemia causing the hypertension with the occlusion of the vessels. You may be of African American background. You may be a diabetic, obesity, aging, stress, excessive smoking, or alcohol ingestion. Now those are all causes of essential hypertension. And 10% though are related to either renal or endocrine disorders, and they're classified as secondary hypertension. So that's just a little definition between the two. Okay, hypertension. There are selective regulators of blood pressure. The kidney and the blood vessels strive to regulate and maintain a normal blood pressure. And you can kind of look, there's a figure on 44 that kind of gives you an example of this. The kidneys regulate the blood pressure via the renin-angiotensin-aldosterone system. Renin from the renals, it stimulates production of the angiotensin 2. That's a really potent vasodilator, and that causes a release of aldosterone, which comes from the adrenal hormone, and it increases sodium retention and water retention. So retention of the sodium in the water then increases the fluid volume within the body, that then increases the blood pressure. And that little chart kind of gives a little overview of that. The regulators of blood pressure within the body are your baroreceptors at the aorta and carotid sinus. They are the big one. Also the vasomotor center within the medulla, that also regulates the blood pressure. There's catecholamines such as norepi from the sympathetic nervous system, like we talked about before, and the epinephrine from the adrenal medulla that also help regulate the blood pressure. They cause an increase in blood pressure through vasoconstriction. And then you have your hormones. You have your antidiuretic hormone, your ADH, and your, as we talked about earlier, your atrial neutropenic peptide, and your ANP and your BNP. Those both contribute to blood pressure regulation. There's psychological risk factors that also have to come in play with this, Some of those are an excessive intake of saturated fat and simple carbohydrates, and alcohol also tends to increase renin secretions. If anytime your blood pressure is greater than 140, drugs are generally ordered and should be combined with a hypertensive therapy if you're greater than 140 and contend. But if you have mild hypertension, it's just starting, you can start things like stress reduction techniques, exercise to help increase that HDL, salt restriction, decrease your alcohol ingestion, and lose some weight. Those things might help your blood pressure, and I've seen people that actually get even like a 20% drop in their blood pressure just by correcting some of these non-pharmacological controls of hypertension. If you'll look on your chart here, and I can't see which page it's on, but there are some guidelines for determining hypertension. The 7th report of the Joint National Convention on Prevention, Detection, and Evaluation and Treatment of Blood Pressure, better known as the JNC7, is the gold standard on hypertension treatment. So this gives a little overview of that, the determining factors of hypertension. And as you can see, normal is less than 120 and less than 80 diastolic. So pre-hypertension actually is 120 over 80 to 139 over 89. Hypertension, then stage 1, does start at 40 over 90, 140 over 90. FYI is that 2 out of 3 people with hypertension have uncontrolled blood pressure, or they're not optimally being treated. So that's something you need to really be concerned with any of your patients. The JNC7 recommends that if blood pressure is 20 over 10, so if the diastolic is 20 milligrams of mercury above and the diastolic is 10 milligrams of mercury above the goal, a drug regimen should be started. Cardiovascular disease is 2 times higher risk with every 20 degrees up as the systolic pressure goes up, or every 10 degrees that diastolic goes up, and that's starting at looking at a blood pressure of 115 over 75. So see, that's not much. So if you're thinking your patient has 135 systolic pressure, they have already increased their risk of cardiovascular disease more than the person that has a blood pressure of 115 systolically. That makes sense to you. The first line of defense that we use for antihypertension would be your diuretics. Diuretics promote sodium depletion, and in doing so, they decrease the extracellular fluid volumes, and these are the first things we go to for the mild hypertension. Excuse me. These are your thiazides. Real common, most frequently prescribed one is their hydrodiaryl. This one can be used alone or combined with other hypertensive medications to get a better results, because some of your hypertensive medications can actually cause a fluid retention, so they're given with a diuretic to help decrease that. You also have your loop diuretics, which is like Lasix, or your combinations of HCTZ with a potassium-sparing drugs or diuretics, or like an ACE inhibitor. The things you got to watch with these is you got to think about your potassium losses, your chances of hyperkalemia, and making sure that your patients know the signs and symptoms of these. You don't want to use those some of these drugs if your creatinine clearance is low, so you need to be sure to be aware of that. The next group of drugs that you have is your simple lytics, or your sympathetic depressants. There's 5 groups of these drugs, and they block either the beta or the alpha sites. And as you can see, they're listed here: your beta adrenergic blockers, your central acting alpha-2 agonists, your alpha adrenergic blockers, your adrenergic neuron blockers. These are your peripherally acting sympathizers, your alpha-1 and beta-1 adrenergic blockers. Your beta-adrenergic blockers that are used for hypertension. Some of them are non-cardioselective, beta blockers, and that would be like your propranolol, your Lopressor. There's contraindications using those because of since they're non-cardioselective, you also can get into some problems with your COPD patients. Then you have your cardio-selective beta blockers, and these, you shouldn't, clients that take with diabetes, these are contraindicated for them. So they usually have to go on like an ACE inhibitor or an ARB. These beta blockers can be used with or without diuretics. A lot of times they don't respond well, especially with like African Americans. They do not respond well with beta blockers alone, and they must have a combined diuretic with them to make them work better. There's some more tables here. Table 44-2 is your antihypertensives. You can look at your beta blockers and your central alpha-2 agonists with that. Also review chart 44.1 on imetoprolol. That's a real common drug that's given and something you need to be aware of. And there's a nursing process you can kind of read through, and they're on antihypertensives and the beta blocker. You need to review those because those are some drugs that are used frequently. Some of the side effects with the beta blockers are a marked decrease in your blood pressure. You can have some insomnia, some depression, nightmares, and sexual dysfunction. Your nursing interventions are to make sure your patients realize don't just stop taking beta blockers, because you can have a rebound hypertension that may result, and it might be worse than what they had before, so you want to watch that. Then we get into your alpha blockers. The action of these meds are they block that alpha adrenergic receptor site. This results in a vasodilation and a decreased blood pressure. Some of these drugs are your Cadura, your Minipress, your Hytrin. Refer to table 44-3 on your antihypertensives, and you can get more information about those. Also look on chart 44-2. It talks about the prazosin, which is your Minipress, which is a drug that's also frequently used. On your central acting alpha-2 agonists, they're contraindicated in any liver function impairment, so you want to watch your serum liver function on your lab results. The side effects with that is your sodium and water retention, so you get a lot of dry mouth and bradycardia. Diuretics are frequently prescribed to avoid that fluid retention that is caused from this drug. And again, you want to avoid abruptly stopping this drug. Make sure your patients realize that, because the rebound hypertension can result. On your angiotensin converter enzyme, or your ACE inhibitors, these were developed back in the 1970s. These inhibit the formation of the angiotensin II. They cause the vasoconstrictor, and it blocks the release of the aldosterone. Examples of this ACE inhibitor is your captopril, which is a very common one that's used. Again, African American adults and older adults don't always respond with monotherapy of the ACE inhibitor, so they do a lot better when they're given with a diuretic. So that's something that needs to be thought about. ACE inhibitors are never given during pregnancy. They should not be taken with a potassium-sparing diuretic like spirolactone or with any salt substitute containing potassium, because of the risk of hyperkalemia with those. The other thing with this medication is they have an irritating cough as a side effect, and a good number of people taking this do get that cough, and it's very annoying to them, and they'll end up wanting to get off of the drug just simply for that reason. So you have these ARBs, the angiotensin II receptor blockers, and these are very similar to your ACE inhibitor, and they prevent the release of the aldosterone, and it's different because of where on the side of the angiotensin II that they block. They block at different sites. An example of an R is your Cozar, your Sartan. These are less effective in African American adults and older adults with the monotherapy. So again, they do work if you add a diuretic with them. The one good thing about these is they don't have the cough side effect like the ACE inhibitors do. Then you get into the calcium channel blockers for hypertension. These slow the calcium channels in the heart and the vascular smooth muscle. So in your myocardial and your vascular smooth muscle that slows that channel down. If you have calcium, that increases that muscle contractility that we talked about earlier. It also has a peripheral resistance in increasing the blood pressure that calcium does. So this blocks this by promoting vasodilatation. The first one that was developed was your verapamil, but now we have other drugs along this line. It's your Cardiozam and your Norvasc. Some of the side effects of these is your edema, because it may cause the peripheral vasodilation, but you'll get the edema with that. And one of the things you need to be sure to tell your patients is to avoid grapefruit juice, because if you take that with your medication, it will increase the drug effect. Here's a list of a few more other antihypertensives. The nitroprusside, that is only used in ICU settings. It is an IV drug, and it relaxes, it dilates the muscle, the blood pressure out, and you can get a fast response with that. It's also very short half-life. When you turn it off, and you'll get a rebound effect very quickly with that medication. The side effects to that is the reflex tachycardia, palpitations, restlessness, agitation, and confusion. So just some others that are out there to work with. Practice question number 1. The client's blood pressure was 142/82. The healthcare provider prescribes a diuretic to lower the blood pressure. The nurse knows that this blood pressure medication is, that this blood pressure, don't back up, the blood pressure 142/82, but this blood pressure is within the pre-hypertensive range, B indicating stage 1 hypertension, C indicating stage 1 hypertension according to a diastolic pressure, D indicating stage 2 hypertension according to the new guidelines for hypertension. So what do you think? It's B. The BP of 142/82 indicates stage 1 hypertension. The systolic range for stage 1 is 140/159, and the diastolic range for stage 1 is 90/99. Okay, so the next question here. A client is receiving an angiotensin II receptor or blocker, which is your ARB, which does the nurse recognize as an ARB? Valsartan, amlodipine, captopril, metoprolol. Which one do you think? It's A. One of the things you can remember to keep these in mind is look at your suffix on these drugs. ARBs always have the suffix of sartan. Valsartan is an ARB. Your amlodipine, ACE inhibitors, amlodipine is a calcium channel blocker, and they all end with that pine, generally speaking. Captopril is an ACE inhibitor, where it has a suffix of pril, and beta blockers like metoprolol have that suffix of the LOL. So that'll help you just kind of remember that. There's one more practice question. The nurse realizes that the common side effect of an ARB is constipation, nervousness or tremors, asthma attacks, or dizziness. The answer is D. One of the common side effects of ARBs is dizziness, diarrhea, insomnia, occasional cough, and upper respiratory infection. All right, that ends the videos for week 2. I hope these were helpful to you, and if I can do anything to help, please give me a holler. Sorry for my stuttering. I'm on night shift right now. So anyways, I'll see you later. If you need anything, give me a holler. Thanks.